Who knows? I mean, I think that's a really interesting question. I think that so many things are being globalized and becoming more enriched and interesting because of that. And so, you know, certainly basic issues about behavior and disorder behavior finally is catching up with that. But also, I think a real big change is how mental health has really shifted in its relevance to overall healthcare. We look at it differently once we started looking at disease burden around disability, really changed the sense of within public health as to the relevance of mental health conditions. And also increasingly its impact, it's being an obstacle to other healthcare objectives. In terms of the cost effectiveness of overall healthcare, in terms of overall mortality, morbidity, being able to achieve other chronic disease goals, as well as you know, increasingly appreciating its role in all sorts of other social issues that matter to us. And so both things, just the globalization of knowledge and the real value add that's had in a lot of fields, and then the appreciation of the multiple dimensions in which you really can't escape these issues. Yeah, I mean, I actually spend most of my work life in the New York City hospital system, and there's also been a real sea change there. And I think this is happening more in the US healthcare system as it starts confronting the costs of the system. And an appreciation that a lot of the costs are coming from patients who are burdened not only with a lot of medical issues, but especially comorbid with mental health issues. That those individuals are really the drivers of a lot of our emergency room visits and our long inpatient stays and our multiple needs for acute care and our lack of success in meeting other health targets. And so there's been a real change with the Affordable Care Act and attention to putting incentives for healthcare systems to both achieve health targets and to do it in a cost-effective way, and to start being paid that way. So they're incentivized to do it in a cost-effective way and meet health outcomes. That with those incentives, it's become unavoidable to not really take head-on the comorbidity of mental health disorders. So I now have conversations that go somewhere that never went anywhere, even a year or so ago, and really thinking innovatively about really fully integrating mental health capacity within primary care, rethinking about the presence of the healthcare system, reaching into the community to be part of more upstream early intervention and ongoing care management solutions. And these are ideas that I was first exposed to looking at low-income countries with acompañadores and community health workers. And so the global field is really starting to get a problem list of issues that really are globalized. How do you design the workforce? How do you engage community solutions into how the healthcare system works? The issues we were talking today about how do you modularize care and think about multiple different kinds of people who can be part of delivering care, often called task shifting. I mean, all of those things really are now global conversations and back and forth learning about best practices, and I think really accelerated by its globalization. Sometimes I feel like there are less obstacles to doing it there than in the developed world, where there are really sort of entrenched roles and turfs and so forth, that it's sometimes harder to migrate care and embed it into one setting when it's been in another for so long. So in the developing world, I think there's, in some ways, by necessity, this understanding of task sharing and task shifting, and I think one of the lessons from the Millennium Development Goals and from the huge and aggressive and ambitious efforts around HIV and tuberculosis and malaria was a realization that that siloed approach really missed opportunities for system strengthening, for building capacities that cut across disease categories and really enable systems to manage their own growth and transformation and innovation and strategies. And so I think there's a real fertile ground for thinking more holistically and systemically in developing countries than there has been. And also, you know, people talk about stigma a lot. My approach to stigma around mental health is, you know, it's real, but it's hard to combat directly. I don't know what really works other than to come up with really good solutions. I think stigma fills a vacuum when there aren't good solutions. And what I found in developing countries is you don't have to convince people that they have to address mental health care needs. They'll agree with you in a second. It's show me how. What's the plan? How can I do with the resources I have? And so what I was trying to get at in the talk today was we have to come up with, and I think we have the basic knowledge we need to come up with, some really basic planning templates and structure, you know, the real basic building blocks and methods to build from a menu of standard skill sets that give guidance and focus about the key building blocks, but also allow local adaptation and growth and innovation locally. Yeah, I mean, they see it. It's right in front of them. I mean, we're right when we say that mental health is implicated in all sorts of social issues and has to be solved if we also want to solve those social issues. And they're proof of it. They see it in who they're arresting and who gets incarcerated. They see it in who's failing out of school and having trouble in school. And they see the results of dropping out of school. And they see these complex clusters of pathology that I was talking about, and where behavior and mental health conditions factor into that. And so they're in the middle of it, and they don't have the tools for it. And so they're a huge resource to really provide very proximate points of contact for solutions to be delivered, because they're right there. I did some focus groups with people in New York City returning from prison, and asked them, you know, and their families, and asked them, what gets you back into prison? You know, a lot had been to prison multiple times. What gets you to reoffend or into this cycle, this spiral? And they would mention things like, you know, relapsing an addiction, or being depressed, or not having the social supports or using them the way they need, or being unemployed. Now I don't know how to do a lot about unemployment. That's not my skill set, but I know how to do a lot about those other three things. But we're not reaching these high-risk folks and the connection of mental illness to their spiral. We're not reaching them with the structures we have, with the designs we have, and we never will, unless we push out the skills needed to interfere with that spiral right at the ground level. And we have to do that by rethinking who a mental health provider is and extending the capacity of health systems really deep into communities through these other sorts of professionals and sectors, as well as being creative about you know, what a community health worker can be. So out of that focus group work came this idea of piggybacking off a program in New York City that uses formerly incarcerated folks to try to intermediate in gun violence events in their community. And so we thought, well, let's train them up. So they're right in the middle of that mix of social pathologies and fueling of mental health and social outcomes. So they're right in the mix of that, a high-risk setting. So why don't we skill them up with basic evidence-based counseling methods? It'll both improve their violence mediation skills, but it also allows them to be a first point of contact really around mental health care, and to potentially bring people in who need it to more formal care. And that changes the role of the healthcare system, not as much as a provider, but as a coach and an enabler of community capacity to be a front line. Well, there's a difference between cutting costs and cost effectiveness. And I think that's really, there's a real smart difference between the two. And smart people get that. The cost effectiveness means that often a big part of quality solutions is to think about more efficient use of your resources. That often the smartest ways to improve care are often the most cost-sensitive ways. That it forces us to think further upstream in a disease course rather than the expensive downstream care, and to really push those solutions as much as possible. So if done smartly, a cost consciousness can actually drive much more preventive, early intervention, other sector collaborative, community-based, upstream kinds of solutions. And those are precisely the kinds of things that we need and are relevant to affect the ways that mental health is relevant to disease burden.
Okay, great.
Legal papers are in process, so, but this grew out of a lot of thinking about this whole relationship of what are the real tools that people need to accelerate this kind of work of integrating mental health care into primary care, especially in community health systems. We know it can work, we know the basic tools, we have treatment guidelines. What's going to always stand in the way of scale up is giving people tools to scale up. So, and those are implementation tools. And we think that the sort of QI package is the package to work with. And it's proven itself in other health conditions, and we're working closely with the folks who proved that that was doable, the Institute for Healthcare Improvement in Boston. And so first we're trying to prove the concept that QI works that way, both for mental health as it's done with other improving and scaling up other health outcomes in low and middle income countries. But then we want to package those tools in ways that are really as widely available as we can make them, but in a setting that allows for collaboration. I refer to as a virtual workspace, where people can share data and learning and have access to these tools and to technical support around them. And so we've decided we should really build an organization devoted to that, collaborating with the Institute for Healthcare Improvement and others. I have a lot of wise people and really smart innovators in integrated health system design. Jürgen Unitzer is at the University of Washington, Lloyd Setter, who is the medical director of the Office of Mental Health in New York State, increasingly on board in collaborating with IHI. And then obviously, as we start to roll out this idea in country settings, is to really see who in those settings become then the champions and the experts in using these methods. And so that's the expanding network. And when we get a critical mass, we hope to show that a lot of this can be done virtually. A lot of this can be done on the web and then build off of there. So the technical answer to your question is A Billion Minds and Lives has a domain name, abillion.org. The website is having some technical difficulties at the moment, so we are in our birth pangs. And our legal paperwork is in process to be a nonprofit corporation in the United States. But our on-the-ground, real-world health systems, test sites and partners and expertise and toolkits are already starting to roll out. And so it's really exciting to see that we can put actionable methods in the hands of folks to really concretely and seriously move towards this goal of closing this billion-person treatment gap. Thank you for covering this issue. Often people think about mental health as it's too wishy-washy, or it's not robust enough, or it's not scalable, or it relies on too much individual expertise and so forth. Mental health is proving to be as standardizable, scalable, spreadable, and deeply reaching form of health modality as we're learning about other conditions and how much they rely on similar sorts of approaches to design. And that we can do that without losing, and in fact, in more reliably incorporating the kinds of things that Judith Bass was talking about today, sensitivity to the qualitative local context. By building it into these more structured approaches to planning, you actually more guarantee that your scale actually incorporates local variation. And that's also the point of really relying on quality improvement tools as well.